Today I am going to talk about congestive heart failure, and we'll start with a case study of a typical case of heart failure. A 60-year-old male patient who presents with history of gradually progressive exertional breathlessness or shortness of breath and easy fatigability since 2 months. And he also gives history of retrosternal chest pain on exertion. He is a case of hypertension and diabetes, but is taking medications irregularly. He also has edema feet. This is a typical case history given by a patient who has congestive heart failure secondary to ischemic heart disease or because of myocardial infarction. And all the points here mentioned clearly indicate that the patient is elderly. He has risk factors like hypertension and diabetes, and he has complaints of shortness of breath and easy fatigability. So we will be speaking about this congestive heart failure. The learning objectives would be to know the definition of heart failure, to be able to enumerate the various types of heart failure and understand pathophysiology, precipitating factors, compensatory mechanisms in heart failure, clinical features, and how to diagnose and manage a case of heart failure. By definition, heart failure is a clinical syndrome which develops when the heart cannot pump blood forward at a rate which is sufficient to meet the metabolic demands of the body, or can do so only at the expense of elevated filling pressures. As per Harrison's textbook of medicine, latest issue, the heart failure is defined as a complex clinical syndrome that occurs in patients because of an inherited or an acquired abnormality of cardiac structure and or function, and develop a constellation of clinical symptoms like dyspnea and fatigue, and signs like edema and rhonchi that lead to frequent hospitalization, poor quality of life, and shortened life expectancy. And I'll explain this in detail subsequently. In mild and moderate heart failure, cardiac output is adequate at rest but becomes inadequate on exertion stress when the metabolic demand increases, and any form of heart disease can subsequently progress to develop congestive heart failure. The types of heart failures in young patients, we have rheumatic heart disease as the most common cause, or congenital heart disease. In middle age and elderly, we have ischemic hypertensive heart disease and myocardial infarction, or ischemic heart disease, which all of these can subsequently go on to develop congestive heart failure. Cardiac output is a function of preload and afterload and myocardial contractility. Preload is defined as volume and pressure of the blood in the ventricles at the end of diastole, and afterload is volume and pressure of the blood in ventricles during systole. And increase in preload, afterload, and decrease in myocardial contractility is responsible for heart failure. Now let us see the mechanisms or causes of heart failure. Ischemic heart disease or cardiomyopathy will result in decreased myocardial contractility and may precipitate heart failure. Pressure overload, which occurs in hypertension, aortic stenosis, pulmonary hypertension, or pulmonary stenosis, and volume overload, which is a feature of mitral or aortic regurgitation or incompetence. Hyperdynamic high output states like anemia, pregnancy, beriberi, and other conditions which can cause heart failure. The final common pathway of all types of heart failure. Prevalence of heart failure is increasing as hypertension, diabetes, and heart disease are increasing. We are experiencing an escalating epidemic of non-communicable disease and lifestyle-driven diseases like hypertension, diabetes, which ultimately lead to, and obesity, which ultimately lead to heart attacks and paralytic strokes. And therefore, as the heart attacks increase, are increasing, the chances of developing heart failure increase, and coronary heart disease or myocardial infarction is the most common cause of congestive heart failure. Hypertension uncontrolled would lead to hypertensive heart disease, dilated cardiomyopathy, rheumatic heart disease, and congenital heart diseases are common causes of heart failure in children or in the younger age group. Heart failure can be classified by a number of ways. There are various types of heart failure. We have left-sided heart failure, right-sided heart failure, biventricular heart failure, and by and large congestive heart failure is a term which is used when there is a combination of both left-sided as well as right-sided heart failure. Heart failure could be systolic or it could be diastolic dysfunction. These terms are not used so commonly now, but systolic heart failure is because of impaired ventricular contraction and leads to a decrease in ejection fraction, which is the amount of fraction of the blood in the left ventricle which is ejected out during systole. So that is now called as heart failure with reduced ejection fraction. And diastolic heart failure, as you know, diastole, the function of diastole is the relaxation of the ventricular muscles. And when the ventricle fails to relax properly during diastole, the patient can develop diastolic dysfunction, and these patients can develop heart failure with a preserved ejection fraction and these patients may have only diastolic dysfunction. This usually occurs when in patients who have left ventricular hypertrophy, which occurs in patients with systemic hypertension and in patients with aortic stenosis, where the compliance of the left ventricle decreases and it fails to relax during diastole, and that leads to diastolic dysfunction. Heart failure could be also acute, which can occur in patients who have acute myocardial infarction, or it could become chronic, and which is the usual one which we see very frequently. Cardiac output could be increased in patients of some types of heart failure when it is called high output heart failure. Usually in heart failure, the cardiac output is decreased. But high output cardiac failure is seen in hyperdynamic circulation, like in patients with severe anemia, beriberi, thyrotoxicosis, and pregnancy. Now, based on the left ventricular ejection fraction, heart failure can be classified as heart failure with reduced ejection fraction when the left ventricular ejection fraction is less than 40%. Normally, the ejection fraction, left ventricular ejection fraction, is between 55 and 76%. When it is less than 40%, it is defined as heart failure with reduced ejection fraction. And heart failure with mildly reduced ejection fraction or mid-range ejection fraction is when the left ventricular ejection fraction is between 41% and 49%. And heart failure with preserved ejection fraction is defined when the left ventricular ejection fraction is more than or equal to 50%. So heart failure with preserved ejection fraction, which is diastolic dysfunction, occurs because of impaired relaxation of the left ventricle during diastole and accounts for more than 50% of cases of heart failure. These causes include hypertension, which causes left ventricular hypertrophy, or hypertrophic cardiomyopathy, aortic stenosis, or restrictive cardiomyopathy, or in patients with constrictive pericarditis or infiltrative diseases like amyloidosis and sarcoidosis, and storage disorders like hemochromatosis and fibrosis of the left ventricle, which can occur as a consequence of ischemia. So these are various situations where a patient can have diastolic dysfunction, and patients can develop heart failure with preserved ejection fraction, where the diastolic relaxation during diastole of the left ventricle is impaired. When a patient develops heart failure, there are a number of compensatory mechanisms or pathophysiology which come into play in patients who develop chronic congestive heart failure. The most important neurohumoral mechanism or compensatory mechanisms include stimulation of the RAS system, which is called the renin-angiotensin-aldosterone system, activation of the sympathetic nervous system, activation of arginine vasopressin or ADH activation, which is ADH is a hormone which is released from the posterior pituitary, and activation of the endothelin system, activation of the natriuretic peptide system, which leads to increased myocardial contractility, vasoconstriction, and salt and water retention. Now let us see what is the activation of RAS means. RAS stands for renin angiotensin aldosterone system. Whenever there is a heart failure, the stroke volume decreases, and this because of decrease in stroke volume, the renal artery perfusion pressure drops, and that is a very potent stimulus for the release of renin from the macula densa of the juxtaglomerular apparatus, and that leads, this renin is a proteolytic enzyme which converts angiotensinogen to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by an enzyme called angiotensin converting enzyme. And angiotensin 2 has got two very important functions. One of them is that it is a very potent vasoconstrictor, and second, that it is a very important stimulus for the release of aldosterone, which is a mineralocorticoid from the outer zona glomerulosa of the adrenal cortex. Now, adrenal cortex has got three layers. The outer layer is the zona glomerulosa, which secretes mineralocorticoids like aldosterone. The middle layer is zona reticularis and fasciculata, which secretes glucocorticoids, and the innermost layer is the zona reticularis, which secretes sex steroids, and the medulla secretes sympathomimetic amines. So, the only stimulus for the release of aldosterone from the zona glomerulosa is angiotensin 2, and therefore angiotensin 2 causes release of aldosterone, and that aldosterone is responsible for salt and water retention from the kidneys, and that leads to edema feet in patients of heart failure. Now, this is another pathway which describes the compensatory pathophysiological mechanisms. In addition to activation of the RAS system, which occurs because of a decreased renal artery perfusion pressure, because of a decreased stroke volume in heart failure, there is also activation of the natriuretic peptide system, and that leads to release of ANP, BNP, and CNP. ANP is atrial natriuretic peptide, which is released by the dilated atria. B was previously called brain natriuretic peptide, is basically now called as B-type natriuretic peptide. It is released from the ventricle wall, and the C-type is CNP, which is released from the capillaries. This is degraded by leprolysine, which inhibits the degradation of this enzyme. So this is another mechanism by pathophysiological mechanisms which come into play in heart failure. A compensated heart failure may get decompensated by a number of precipitating factors which lead to decompensated of a compensated heart failure, leading to hospitalization. And therefore, these factors should be looked for in patients who have heart failure. Most common is arrhythmia. When a patient develops any sort of an arrhythmia, the most common in rheumatic heart disease is atrial fibrillation, and that can lead to decompensation of a compensated heart failure, causing hospitalization. Or if a patient develops intercurrent infection like fever, that increases the metabolic load on the heart, and the heart rate increases, and that may precipitate heart failure. Infective endocarditis is a very important cause of refractory heart failure and a factor which can precipitate heart failure if it develops. And unless and until these precipitating factors are treated, the patient's heart failure cannot be controlled. Then repeated pulmonary thromboembolism, myocardial ischemia and infarction, severe hypertension, and very importantly, non-compliance with therapy and reduction of heart failure medications. If a patient is advised to take medications and he stops taking medications, is a frequent and in fact the most common cause of more factor which precipitates heart failure, causing decompensation of a compensated heart failure. If a person who has compensated heart failure is administered drugs like non-steroidal anti-inflammatory drugs or negative inotropic drugs like diltiazem or verapamil, and these patients can also develop frank heart failure. IV, if it is given in overload, and whenever there is an increased metabolic demand, like in patients with anemia, thyrotoxicosis, pregnancy, physical or mental exertion or emotional exertion, or all the factors which can precipitate heart failure, causing decompensation, leading to hospitalization. There are various stages of heart failure. Stage 1 is called at risk of developing heart failure. These include patients who have no structural heart disease but they have risk factors for development of heart failure, like patients who have diabetes or hypertension, but there is no structural damage to the heart. This is called at risk of heart failure. That is stage 1 or stage A. Stage B is pre-heart failure, patients who have structural heart disease. They may have, but they have no symptoms of heart failure. For example, a patient may have suffered a myocardial infarction and may have ischemic changes in the heart, but still there are no symptoms and signs of heart failure. In that situation, or a patient has a rheumatic heart disease but has no symptoms or signs of heart failure, that is stage B or pre-heart failure. Stage C is symptomatic heart failure, when a patient develops full-blown picture or signs and symptoms of heart failure. When patient has a structural heart disease and has developed signs and symptoms of heart failure, is called symptomatic heart failure or stage C. And stage D is when a patient has advanced heart failure or a refractory heart failure in a very severe form of heart failure, and with marked symptoms and signs of heart failure, require special interventions and may require left ventricular assist devices or may require heart transplantation, that is stage B. So we can stage the heart failure in these 4 categories. But clinically assessment of heart failure, what are the symptoms? These are very important to understand what the symptoms of left-sided heart failure are and what the symptoms of right-sided signs of right-sided heart failure are and why they develop. The cardinal sign of left-sided heart failure is shortness of breath or exertional breathlessness or dyspnea. Now why this occurs is because when there is a left ventricular failure, the left ventricular and diastolic pressure increases because it is not able to pump out all the blood from the left ventricle into the aorta. That results in increase in left ventricular and diastolic pressure, which is then reflected into the left atrium. And we know there are 4 pulmonary veins, 2 from each lung, which open into the left atrium. And the pressure, increased pressure in the left atria is then reflected into the pulmonary veins, that leads to what is known as pulmonary venous hypertension. And once pulmonary venous hypertension develops, the patient will develop, there is exudation of fluid from the intravascular space into the interstitium, and that leads to pulmonary interstitial edema, and from there the fluid may exude out into the alveoli, and that leads to pulmonary alveolar edema. And when pulmonary edema develops, these patients, the main function of the lung, of course, is gaseous exchange, and because of this interstitial and alveolar pulmonary edema, the gaseous exchange does not occur. That means oxygen from the alveoli does not go into the capillaries, and carbon dioxide from the capillaries does not go into the capillaries, and because of this it leads to hypoxemia and hypercapnia, that is decrease in PaO2 and increase in PaCO2. This causes stimulation of the respiratory center, which is located at the pontomedullary junction, and the patient becomes dyspneic. Similarly, the fluid which is present in the interstitial fluid space will also stimulate the juxtacapillary J receptors, which lead to dyspnea. So very important symptom of left-sided heart failure is pulmonary congestion and pulmonary edema, which produces exertional breathlessness, and this exertional breathlessness also can be classified and graded according to what is known as the New York Heart Association classification and functional class of the patient. Orthopnea is another very important symptom of left-sided heart failure, which means the patient becomes dyspneic on lying flat. And if it becomes recumbent, what happens is that the element of gravity is eliminated, and fluid from the lower extremities, more fluid goes into the venous return increases, and that increases the flow to the lungs from the right side of the heart, and that leads to increase in pulmonary edema, and therefore patients are feels better when he sits up in a propped up position, but when he lies down, because of increase in venous return and because of increase in pulmonary congestion, that produces a sense of breathlessness, which is called orthopnea. And paroxysmal nocturnal dyspnea is another very important symptom of left-sided heart failure, which essentially means that the patient was all right. When typical history given by a patient was P and D is that if a patient was comfortable when he went to bed in the night, but after about 2 or 3 hours of sleep, he wakes up with a sense of suffocation and breathlessness, and then he wakes up, goes to a window, takes a deep breath, and his breathlessness somewhat relieved. This is a typical history given by a patient with paroxysmal nocturnal dyspnea, again a very important symptom of a patient who has heart failure. So heart failure, left-sided heart failure, typically has symptoms of exertional breathlessness, orthopnea, and paroxysmal nocturnal dyspnea. And this dyspnea is called cardiac asthma or cardiac dyspnea, or wheezing is there. Wheezing is when the patient, we can hear the sounds of bronchi which are audible. In left-sided heart failure, again, the patient's cardiac output decreases, and therefore he gets fatigued easily. So easy fatigability, effort intolerance is another very important symptom of decreased cardiac output, because when he does some exertion, the muscles require more blood, and which is not possible to increase because of heart failure, and therefore the patients have symptoms of easy fatigability, which is a symptom of left-sided heart failure. Effort intolerance again is because of decrease in cardiac output. Cachexia, cardiac cachexia occurs because patients who have heart failure actually have a lot of nausea and vomiting, and because of nausea and vomiting they is not able to. Why nausea and vomiting occurs is because there is hepatic congestion, and also there is congestion of the of the stomach, and because of that the patient develops nausea and vomiting, does not take adequate food, and that leads to cachexia, which means basically wasting of the muscles. Though his weight may not increase because he is retaining fluid, and his weight may be normal, but his muscle mass decreases, which is called cachexia, which is very similar. Cachexia is a term which we use for muscle wasting, which is seen basically in patients who have cancer. But here cardiac cachexia can also occur in patients who have heart failure. There are some minor symptoms like nocturnal cough, nocturia, and sleep disturbances are some of the symptoms. Mainly these symptoms are of left-sided heart failure. Now this is something which is very important. All of you should remember this classification of New York Heart Association, functional classification of severity of symptoms in physical activity, and which functional class the patient is, you should be able to categorize. Class 1 is there is no limitation of physical activity, and as I told you, limitation of physical activity is a very important symptom of left-sided heart failure. So in class 1 there is no limitation of physical activity, and ordinary physical activity does not cause undue breathlessness, fatigue or palpitations. Class 2 is when there is a slight limitation of physical activity, that means the patient is comfortable at rest, but ordinary physical activity, routine activities, results in undue breathlessness, fatigue and palpitations. Class 3 is marked limitation of physical activity, the patient is comfortable at rest, but less than ordinary physical activity results in undue breathlessness. And class 4 is when the patient is breathless at rest, is unable to carry out any physical activity without any discomfort. Symptoms of rest are present even at rest, they are present. And if any physical activity is undertaken, discomfort increases further. So this is important functional classification, NYHA, which all of you should remember and properly and classify the patient in which functional class the patient belongs to. Another type of respiration which is sometimes seen in patients who have heart failure is known as Stokes respiration, in which there is a period, it's also called periodic respiration or cyclic respiration, which is present in nearly 40% of patients who have advanced heart failure, in which there are apneic phase where there is no respiration. And in that situation, the PaO2 drops, the PaCO2 rises. And this is followed by a hyperapneic phase where drives away the carbon dioxide and increases the PaO2. So this occurs in a cyclic manner, which is called Stokes respiration, which is a symptom of patients who have severe advanced heart failure. Now, what are the signs of left side of heart failure? Let us start with signs. Signs are something which are elicited by the doctor, while symptoms are what the patient tells you. So signs of heart failure, left-sided heart failure. Typical pulse in a patient of left-sided heart failure or congestive heart failure is tachycardia. And why tachycardia occurs is because it is compensatory. What happens is that the cardiac output decreases, and the stroke volume decreases, and therefore to increase the cardiac output, the heart rate increases. You know, the cardiac output is equal to stroke volume into heart rate. The stroke volume decreases, the heart rate increases, so that the cardiac output is maintained. So tachycardia is a very important symptom of impending heart failure. Even before other signs and symptoms set in, tachycardia occurs. And the character of the pulse is pulsus alternans. Pulsus alternans is a strong beat alternating with a weak beat. And why this occurs in left-sided heart failure is because, or in congestive heart failure, is because it follows what is known as the Frank-Starling's law. What is Frank-Starling's law is that the force of contraction of the left ventricle is directly proportional to the initial length of the contracting fibers within physiological limits. Which means what happens in left-sided heart failure is because the left ventricle is not able to pump out blood, certain amount of blood remains in the left ventricle, and that leads to increase in the left ventricular initial length of the contracting fibers in the left ventricle, and therefore the next beat is much more stronger, and this goes on in an alternating fashion. Therefore we get a strong beat alternating with a weak beat, which is known as pulsus alternans. The type of character of the pulse in heart failure is pulsus alternans. And if you auscultate the heart, these patients would have an S3 gallop, and sometimes in diastolic dysfunction in patients with reserved ejection fraction may have an S4 gallop rhythm. So gallop rhythm is something which needs to be auscultated of the heart. There, of course, all signs of cardiomegaly usually are present when the patient develops heart failure. And if you auscultate the lungs, patients will have crepitations in the lungs. Initially, fine end inspiratory crepitations in the infrascapular region, they occur initially. As and when the pulmonary edema increases, the crepitations go on increasing, and they may sometimes, in a very severe pulmonary edema, crepitations may be heard all over the chest. And the type of sputum which occurs in severe pulmonary edema is known as the pink frothy sputum. Why it is pink? Because it contains RBCs, and why it is frothy? Because it contains blood air which is coming out from the lungs. So pink frothy sputum is the type of sputum which occurs in patients with severe pulmonary edema. Crepitations at the lungs, bronchi also can be heard. Sometimes in patients of heart failure develop pleural effusions, which are usually more on the right side as compared to the left side. The right pleural effusions, which are transudate, can occur in patients with heart failure. And of course, all signs of cardiomegaly can be seen in left-sided heart failure. So if you see a patient of left-sided heart failure, patient will be dyspneic. When you say patient is dyspneic, means his dyspnea by definition is awareness of increased respiratory effort. Normally you are not aware that we are breathing, but if you are aware that you need to make an extra effort to breathe, that is called dyspnea. And how do you clinically, while examining the patient, how do you know that the patient is dyspneic? You have to look at the accessory muscles of respiration. The normal muscles of respiration are the intercostal muscles and the diaphragm. And the accessory muscles of the respiration are the sternocleidomastoid and the scalene group of muscles which are present in the neck. And also these are the ali nasi. These are the accessory muscles of inspiration. And the accessory muscles of expiration are the recti in the abdomen. So these muscles come into play only when the patient is dyspneic. So clinically, when will you say patient is dyspneic? Is when these accessory muscles of respiration become prominent. We say the patient is dyspneic. And dyspnea must not be confused with tachypnea. Tachypnea is just increase in respiratory rate. Respiratory rate is normally 14 to 18 per minute. Now, if in patients many times the respiratory rate may increase, and that is known as tachypnea. Tachypnea and dyspnea need not be coexist, and they need not be mutually exclusive, because patient may be dyspneic without being tachypneic, and a patient may be tachypneic without being dyspneic. But patients who have heart failure usually are dyspneic, and they become, and you must have seen in the wards, we keep patients in a proper position. Why? Because these patients are orthopneic also, and therefore they are kept in a proper position, and that indicates that because the patient feels better in a proper position. So, and patients may also have cyanosis. clinically, if a patient has left-sided heart failure, is dyspneic, and because the PaO2 drops in that situation, that clinically cyanosis, which is bluish discoloration of the tongue, may become clinically manifest, and the PaO2 is less than 60 millimeters of mercury. Clinically, cyanosis is manifest, and that is indicative of severe hypoxia. So patients will be having tachycardia, pulses alternans, will be dyspneic, tachypneic, may have a pink frothy sputum, may have cyanotic tinge over the these are all signs of left-sided heart failure. Now, what are the signs of right-sided heart failure? Right-sided heart failure, the patients will have a raised JVP, jugular venous pressure is seen in the necks, and is seen at an angle of 45 degrees. You will see the external jugular vein being prominent there, and that has to be seen properly. There is a method by which you can elicit the jugular venous pressure. So distended jugular venous, external jugular vein there, that is raised JVP, is a very important sign of right-sided heart failure. Why this occurs in patients of heart failure is because, as we know, the patients with right ventricle is not contracting properly, is not injecting blood, pressure in the left-right ventricle increases, which is reflected in the right atrium, and from the right atrium into the right atrium opens the superior vena cava and the inferior vena cava. And the superior vena cava, when it enters into the lungs, into the right atrium, the pressure changes in the right atrium actually reflect into the superior vena cava, because there are no intervening cell valves, and therefore pressure changes in the jugular vein actually are a mirror image of pressure changes which are occurring in the right atrium. And therefore, when the pressure in patients with right-sided heart failure, pressure in the right ventricle increases, pressure in the right atrium increases, and therefore we get a increase in jugular venous pressure and a raised JVP. Similarly, you get a tender hepatomegaly. Liver is enlarged, tender, soft, and that is an important sign of right-sided heart failure. Why this occurs is because in right-sided heart failure, one of the most important tributaries of inferior vena cava is the hepatic veins. And as the pressure in the right atrium increases, because as a consequence of increase in pressure of the right ventricle as a result of congestive heart failure, that results in increase in pressure of the hepatic veins, and therefore there is hepatic venous congestion. That leads to enlargement of the liver, and that leads to tenderness of the liver. And that is an important sign of right-sided heart failure. It's soft, enlarged, tender. Tender means on touching it becomes patient winces with pain, and that is a sign of right-sided heart failure. Another important sign is hepatojugular reflux or abdominojugular reflex, where the JVP may not actually be raised on resting position, but if you just press over the right hypochondrium or anywhere over the abdomen and keep it pressed for about 1 minute, the JVP starts rising. And then you release the pressure, the JVP comes down slowly. That is known as hepatojugular reflux, or also known as abdominojugular reflux. And that is a sign of right-sided heart failure, where there is no frank raised JVP. This is another sign which needs to be elicited. Pitting edema feet is a very important symptom and as well as a sign of right-sided heart failure. Now, why the patients of heart failure develop pitting edema feet is because the pressure in the increase in hydrostatic pressure at the venous end of the capillary. As the right ventricle fails, the right pressure increases there, pressure in the right atrium increases, pressure in the inferior vena cava increases, and pressure in the tributaries increases, and pressure in the venous end of the capillary increases. And pressure in the venous end of the capillary, normal pressure in the venous end of the capillary is 12 millimeters of mercury. Pressure in the arterial end of the capillary is about 32 millimeters of mercury. And this hydrostatic pressure will push blood outside or the fluid from intravascular to the extravascular space. But in patient and the osmotic pressure, which is 25 millimeters of mercury, which is exerted by the plasma albumin, is actually preventing fluid from going out from the intravascular to the extravascular space. And what happens is that since at the arterial end of the capillary, the hydrostatic pressure 32 millimeters of mercury is more than the osmotic pressure. There is some amount of exudation of fluid from intravascular into the interstitium, extravascular space, which is immediately reabsorbed at the venous end of the capillary, because the hydrostatic pressure at the venous end of the capillary is much less than the osmotic pressure, and that leads to, that is the usual thing. But what happens in heart failure is because of back pressure, because of there is an increase in hydrostatic pressure from at the venous end of the capillary, more than 12 or more than 20, and that leads to exudation of fluid into the interstitium, that results in edema feet. Now it is very important to understand that edema which occurs in heart failure is dependent edema, which means it is more during the in the evening if a person is upright, and it becomes less in the morning when the person has taken rest and has become recumbent, and if a person is bedridden, then the edema would be maximum in the sacral area. That is sacral edema in bedridden patients. Patients may also develop ascites and anasarca because of heart failure, but typically the patients have edema feet. So typical signs of right-sided heart failure, just to revise, there is raised JVP, palpable tender liver, and pitting edema feet. How to elicit pitting edema feet? You have to press over the bony prominence lens like the medial malleolus for not less than 20 seconds, and you will get a pit there. That is pitting edema feet. This needs to be differentiated from non-pitting edema, which is a feature of mixed edema or filarial obstruction, or lymphatic obstruction, which occurs in filariasis. So these are the important signs and symptoms of heart failure. Now this is a typical picture of a person who has raised JVP. You can see here the JVP is raised over here. Patient is in an upright position, which shows that the patient has got a raised JVP, which is a sign of right-sided heart failure. When we saw talk of congestive heart failure, it's a combination of both left and right-sided heart failure. There is another type of classification in heart failure in acute myocardial infarction, which is called the Phillips classification. Phillips class 1, we say the patient is in Phillips class 1 in acute myocardial infarction when individuals have no signs and clinical signs of heart failure. Class 2 is when patients have crepitations and crackles and rails in the lungs. There is an S3 column when they have elevated GBP, but the crepitations are less than half of the lungs. And Phillips class 3 is when the patient has frank pulmonary edema. All over the chest you can auscultate crepitations. And Phillips class 4 is when this is also associated with cardiogenic shock. That means the blood pressure is less than 90 systolic. So this is another way in which you can classify Phillips classification, which is usually used in heart failure, which is usually used in patients who have acute myocardial infarction. There is also Framingham criteria, major and minor criteria. These are not routinely used, but these are very commonly used in patients where research has to be done on heart failure, where objective science has to be done, and objectively heart failure can be diagnosed by applying this Framingham criteria. The criteria are very simple, similar to the ones which I have just mentioned. So we have specific investigations which need to be done in order to diagnose heart failure. The most common investigation which is done is ECG. So we have to investigate the patient. Once we have made a clinical diagnosis of heart failure based on signs and symptoms, we want to know what is the cause of heart failure, what is the precipitating factor for heart failure, and very specific investigations need to be done. The most common investigation which is routinely done is ECG. ECG will tell you whether the patient has left ventricular hypertrophy or ischemic heart disease, or there is constrictive pericarditis. So we can get some idea about the cause of the disease. But the most common way in which the etiology of heart failure and the structure of the heart can be etiology, type and severity of heart failure can be assessed is by doing the 2D echocardiogram. And we can also do the X-ray chest, which will tell you cardiomegaly and also pulmonary congestion, signs of pulmonary congestion. Thank you very much, and in the next class we will discuss the management of heart failure, which will include investigations and treatment of various. Thank you very much for your patient listening.